I think that patients with cardiovascular disease have a heightened level of systemic inflammation baseline, which is part of the disease process. And so we know from lots of studies that combating that underlying baseline heightened inflammation is probably important in the long-term progression of cardiovascular disease. And then on top of that, patients with cardiovascular disease have their clinical problems tend to be acute events, acute on chronic events. And in those situations, they have a very increased inflammatory response. Some of those events are natural events like a heart attack or a stroke or a clot in the leg, and some of them are surgical events like procedures that we do, angioplasties or stents or so forth. In either of those cases, we're triggering an acute inflammatory response on top of a baseline chronic inflammatory response, and the degree to which the patient, resolves those, I think does have a significant impact on their clinical outcome, on their progression, and on their recovery. So the science around resolution is very exciting from a cardiovascular standpoint because it offers a potential to reduce disease progression in a chronic setting, but also in an acute setting to perhaps allow the patient a faster recovery with less clinical sequelae of the event. So I think the future there is very bright. The questions really are how best to leverage the science in the clinical arena. The science is quite compelling, in animals, and some of the preclinical and early clinical data is compelling. I think what we're still unsure of is exactly how to maximize the SPM at the place where we need them, at the time that we need them, in the location, whether it's the heart, brain, or vasculature. How do we get them there exactly in a timely fashion at the right dose to get the outcome we want? So that's where I think the clinical trials need to go. I think, again, similar to what I was just saying, peripheral vascular disease actually is growing globally. It's a pandemic. It's related to aging of the world's population, and particularly the rise of diabetes, as well as metabolic syndromes and obesity. And because of the success we've had in medicine of either preventing or allowing people to survive their first heart attack or stroke, their burden of peripheral vascular disease continues to grow as they age. So we have a huge population of people with disability related to peripheral vascular disease and needing interventions. We don't fully understand why some people progress to have bad clinical endpoints versus just manage to sort of live with the disease and not have clinical problems. So I think the concept there, again, of affecting the balance of inflammation and resolution may likely allow people to live with the disease better, function better without requiring procedures to correct it. And then again, when we get to the point of actually having to address a vascular blockage or repair a vessel, I think getting that to heal properly is the next step. And so I think in vascular patients, those are the two scenarios, the chronic treatment. But then for me as a surgeon, I'm very interested in applying this to the patients who are about to get procedures to allow them to get a better systemic as well as local recovery. Interventional technologies, percutaneous treatments, minimally invasive ways of opening arteries have become very prevalent, and they allow us to be able to do a lot of treatments without actually doing open surgery. Balloon angioplasty and stents, and even putting covered stents through small channels allow us to treat lots of things. And then we sometimes do have to do open surgical care with bypasses to replace or bypass blockages. In all these cases, though, we create an injury to the vessel, and there's a wound healing response that the artery goes through, just like if it was an incision in your skin. And in some people, it gets to be a little bit more excessive, and it causes the vessel to re-narrow pretty quickly. So in our field of peripheral vascular disease, it's actually pretty common for patients to need repeat procedures. Maybe 40% over the course of 2 to 3 years will have a recurrence, which is a pretty big problem when you think about the scale of the people with the disease. So the current treatments that we have here, where has been some gain, is using really almost a cancer-like drug mentality. to reduce scar tissue growth using cancer drugs to kind of block cells from growing, and there's toxicity associated with that. We're applying cancer drugs to arteries, and as a result, we have to use extra blood thinners because of the damage to the vessel. And in fact, what we're actually doing with these drugs is we're delaying healing rather than accelerating it. We're trying to prevent any healing at all, which is not really very good. So we need new options that are less toxic, that can lead to a more controlled and resolved healing response without using, very, anti-cancer type drugs in this setting. So I think that our research is using some of the chemistry from SPMs towards that end, whether we can apply it in an operating room setting as a coating on a balloon or stent, or in some other way to address the treatment at the time. I think that's a novel way to potentially address the problem in a more physiologic solution for the patient than as a chemotherapy mentality. The current drugs like paclitaxel and others that are used in drug-eluting stents delay healing. They basically, not only do they stop the tissue growth that you want to stop, but they also stop the endothelium from healing, which means that the vessel is chronically exposed to the risk of clotting. So they basically stop it. We don't really want that to happen. What we really want is the artery to heal properly and then stop its inflammatory response. So what we've seen with SPMs is that they actually promote endothelial function and endothelial recovery while sort of suppressing some of the inflammatory and underlying smooth muscle responses that allow the vessel to maybe heal more physiologically. I think that one of the challenges that we have in translating the SPMs from nutritional mentality, which is a whole nother area we can discuss, into actually drugs, and particularly in the area of vascular drugs, is figuring out the right formulation to do it. And so, because the naturally occurring compounds are rapidly metabolized, we need more stable analogues to be able to study and to use in clinical trials, and also if we're going to add them to devices to allow the devices to heal better. So I think the RVD1 and RVD2 pathways are of great interest in vascular disease. We have now at least one or two stable analogs of RVD1, which we've been interested in looking at. Whether these are the best, this is first generation. Whether these are the ideal ones for this indication, I think we don't really know. But I think what we're looking for in the chemistry and what we're excited about, at this meeting and at others, is to see that, drug company mentality starts to come into the field to actually produce compounds that are a little bit more stable and a little bit more durable in their activity and a little easier to handle in terms of storage and ways to adapt them to different types of either infusion or direct incorporation with devices. As a vascular surgeon, one of the things I'm most interested in is studying the surgical recovery phase in general. I think it's a great opportunity to try to determine how to better prepare patients for an easier surgical outcome and a more rapid recovery. So I think the kinds of clinical studies that I can see that could actually be started any time are thinking about regimens in different types of surgical patients, whether they're vascular patients, orthopedic patients, cancer patients. They share some common features, especially aging and other metabolic factors that make them potentially at risk for surgical site infections, delayed healing, and prolonged return to full function. So I think some studies need to be done to further that concept along as far as and they need biomarkers that we can measure, because I don't think we can just launch into studies and look for big clinical outcomes. We need to have some integrated biomarkers to tell us if we're picking the right dose. Do we need to treat for 3 days or 3 months before surgery, and for how long after? These are questions that I have, and I think we can use some of the chemistry and also some of the cell biology of bacterial clearance and other things to design some studies that will sort of move us along the line towards a surgical type optimization of the patient. So I think that's an easy one to think about right now, because we don't really need new formulations. We just need to figure out which ones are, how to deliver them and what's best. And then beyond that, I'm very much interested in thinking about the analogues and ways to apply them directly, either injectable or directly to blood vessels at the time of procedures.